Good morning, everyone. I'll be presenting on a topic pleurodesis, and I'll be presenting on a basis of indication, techniques, and outcomes of the procedure. I am Dr. Sandeep Sapkota from BPK MCH. And the contents of my topics would be the introduction of pleurodesis, small history, indication, techniques, contraindications, and some literatures. And starting with the introduction, the pleurodesis simply means that it's a procedure that obliterates the pleural space to prevent the recurrent pleural effusion, pneumothorax or persistent pneumothorax. Pleurodesis, it helps to alleviate dyspnea, it reduces patient's discomfort, it minimizes the hospital stay and lowers the treatment cost, particularly for patients with limited life expectancy. So we can term it as a palliative procedure. Starting with the small history, in 1901, Spengler performed the first pleurodesis using 50% glucose for tubercular effusion, and then after 5 years later, he used silver nitrate instead of glucose. And in 1935, it was Bethune who first proposed using iodized talc to create the adhesion, and it is the most commonly used pleurodesis agent till now. And in 1941, Churchill described pleurodesis by mechanical abrasion. And in 1958, Chambers described talc in malignant diseases. And in 1963, Roche and co-workers reported talc during thoracoscopy. So if we talk about the anatomy and pleural dynamics, so pleural fluid, they are usually produced by the capillaries in the parietal pleura and drained by the lymphatic vessels. In these two pleural spaces, linings, that is parietal and visceral pleura, there is a potential space which is usually filled by some amount of pleural fluid, which helps in maintaining lubrication and lung expansion. And the imbalance in these dynamics, the hemostatic and oncotic pressure, the hydrostatic and oncotic pressure in these capillaries will lead to the pleural effusion, which we will see in the next slide. So if we see here in my left side, it's a parietal pleura, and in my right side, it's what happening in the visceral pleura. And in parietal pleura, we can see there's a stoma, which helps in drainage of the fluid to the lymphatics. So excess pleural fluid will be drained to the body, returned to the body via lymphatic system. So this is what's happening, and there is a homeostasis between the hydrostatic pressure and oncotic pressure between the two pleura and the space, which will, if the imbalance between this dynamics will lead to the recurrent pleural effusion, or let's simply say will lead to the pleural effusion. So this is a very important illustration of a pathophysiologic mechanism that's happening in the pleural space in case of the malignant pleural effusion. Here we can see there's a cancer cell being shown in the upper endothelium, upper pleura, and the cancer cell that has invaded the pleura. So it induces the VEGF, and that's a growth factor, endothelial derived growth factor, and another is nitric oxide. So all of these modulators, they are the vasodilators. They increase the capillary permeability, and they further the neutrophils are recruited to the pleural space by the mesothelial cells, as the tumor cells are kind of foreign body, which will induce the inflammation and ultimately release the interleukin 8 and other mononuclear cells. So all of these together will cause the pleural effusion. So increased inflammation inside the pleura and an increased vascular permeability will cause the fluid to move to the pleural space. And this is the most likely pathophysiology for repeated pleural effusion in case of malignancy. Starting with the mechanism of pleurodesis, so all of the pleurodesis agent are usually an irritant agent, or it can be mechanical as well. The irritant agent are TOC as well as doxycycline, and they causes inflammation of the pleural layer. To summarize, the neutrophil influx happen within the 24 hours, and the most important Characteristic of mesothelial cells are they also host the resident monocytes, which also help in rapid inflammation. There is also a role of interleukin 8, which correlates with the neutrophil count, and cytokine releases, where the neutrophil perpetuate inflammation by secreting cytokines. After all of the cascades of the inflammation happening in the pleural space, there will be a formation of the fibrin, and fibrin will be further stabilized, making a fibrous pleural sac. And the corticosteroids they usually inhibit the inflammatory response associated with the increased pleurodesis failures, as suggested by many literatures. And after the pleurodesis, after the fibrosis and adhesion, it prevents further fluid accumulation or the air leakage, as the potential sac is obliterated now. So this is a small flow chart showing the mechanism. Here the mesothelial stimulation by interleukin 8 due to any sort of irritant induces the neutrophil macrophage, which induces the MCP1 protein, which helps in the fibrin reticulum. The mesothelial stimulation directly activates the coagulation due to the because of monocytes, as I talked, which also helps in fibrin reticulum. And mesothelial stimulation which inhibits the fibrinolysis by inhibits the fibrinolysis, which helps in fibrin stabilization of the fibrin reticulum. Ultimately, the fibroblast migrates into the fibrinous reticulum, and the adhesions between the two surfaces happen. Starting with the indications, the malignant pleural effusion is still the most common indication for the pleurodesis, and some other indication can be refractory, symptomatic non-malignant effusions. Example: chylothorax, hepatic hydrothorax, nephrotic syndrome, and heart failures as well, where the hydrostatic pressures is the main cause of pleural effusion. And persistent or recurrent pneumothorax are also indication. And we'll discuss in the next slide. The pleurodesis can be divided into chemical as well as mechanical, and mechanical are used. The indication for mechanical pleurodesis is similar to chemical pleurodesis, but it also manages the underlying pathology, such as in VATS. After the VATS, we can simultaneously address the pleurodesis and resect the subpleural blebs, or even do some diagnostic procedure like biopsy. Or the bulle causing recurrent pneumothorax can be addressed during.
Primary spontaneous pleurodesis, certain indications for the surgery. So we can discuss later. We'll just go later.
And on the contraindication side, the major contraindication is the non-expandable lung. It is commonly seen in malignant pleural effusion due to the lung entrapment, or maybe caused by endobronchial obstruction or malignant visceral pleura involvement. Since the non-expandable lung, they prevents the visceral and parietal pleura opposition after the fluid drainage. The pleurodesis failure is high, and indicators are hydropneumothorax after thoracentesis are usually non-expanded, inability to fully evacuate pleural effusion, severe coughing or central chest pain during fluid aspiration, and increased pleural pressure negativity leading to recurrent effusions are also indicators of high failure or contraindicated for pleurodesis. So BTS guideline they recommends intermittent pleural drainage with indwelling pleural catheter for malignant non-expanding lung rather than pleurodesis. And next is the pleural elastance in the contraindication section. Elastance means the fall in pleural pressure after draining 500 ml fluid. How much pleural pressure falls? It is usually measured by pleural manometry. The elastance more than 19 per centimeter water per liter predicts the pleurodesis failure. Medical pleurodesis is contraindicated in high elastance. Mechanical pleurodesis like thoracoscopic ion abrasion, or if needed decortications are. So in this we can see the pleural manometry device, which is a pressure measuring device from the pleura. We can insert the needle with the device inside the chest cavity, and then the device will measure the pressure inside the pleural space. So two things we have to keep in mind is, one is expandable lung, is another is entrapped lung. And in an expandable lung, after we have drained the fluid, there is a gradual fall from positive to the normal negative pressure of the pleural space. And in case of intrab lung, the lung is already negative and there is already negative pressure, and there is an abrupt fall to the more negative after the pleural tapping, which might go more than 20 centimeter of water. So we can see here in this chart, it is taken from the study of Chawla et al. From India. So here the empty open circle, which is in the case of plain hydrothorax, after the fluid has been removed, there is a gradual fall. There is not an abrupt fall, whereas in blue closed circle there is an abrupt fall, which indicates the intrap lung. And in the red circle triangles, closed triangles, we can see this is also intrap lung. There is a rapid fall in abrupt fall in pleural pressure after the pleural tapping. It has reached to more than 60 centimeter of water. These manometric devices are also useful in prevention of the rapid re-expansion pulmonary edema. In case of the used pleural effusion, we can stop the drainage if pleural pressure drops below the minus 20 centimeter of water.
And other contraindications are active pleural infections like empyema, severe coagulopathy, significant patient instability, which can be a general condition of patient, as well as hemodynamic instability, and lack of patient consent, and even greater than 150 ml drainage per day ongoing through chest drain or X-ray that shows a large residual fluid volume is also in contraindication because of the high failure rate. And patients with life expectancy of less than 3 months should be treated with pleurodesis, should not be treated with pleurodesis, but instead they can be treated with repeated thoracentesis with indwelling pleural catheter as well to relieve the dyspnea. And other risk factors, these are not the contraindication but risk factors for unsuccessful pleurodesis. They can be previous thoracic irradiation and chest tube duration of more than 10 days. And now the types of pleurodesis, we can see there are two types of pleurodesis, chemical as well as mechanical. In chemical pleurodesis, talc is usually used, most commonly used. Talc can be used as slurry as well as powders. Slurry is when we used it via the intercostal drainage in a bedside, and powders is used in a dry powder form. It is usually used for mechanical pleurodesis. And in many literatures, powders pleurodesis has shown the better results than slurry pleurodesis. And other chemical agents which we'll discuss as well, but to mention some, these can be doxycycline, bleomycin, povidone iodine. And in mechanical, pleurectomy or decortication is also mentioned, and thoracoscopic abrasion of pleura can be done. This is taken from the BTS guideline 2023. Thoracoscopic and talc powders pleurodesis versus chest drain and talc slurry pleurodesis. And it is recommended the talc slurry or talc powders may be offered to the patient with MP to control fluid and reduce the need for repeated procedure, whereas the good practice is if the diagnostic procedure is being conducted at thoracoscopy, talc pleurodesis is reasonable, then it should be conducted in the same setting via powders. Starting with the chemical agents, to name some, on antibiotic section it can be tetracycline, erythromycin, minocycline and doxycycline. In a cytostatic agents can be used such as mitomycin C, bleomycin, cytarabine, doxorubicin, etoposide and mitoxantrone. And the bioactive agents like bacteria, Corynebacterium parvum and Streptococcus pyogenes, A3 or OK432 can also be used. And other agents like radioactive colloidal gold, quinanstrin, transforming growth factor, even autologous blood and lipotrichoic acid are also being used. And antiseptics like silver nitrate and iodopovidin are used, which are cheaper and equivalent results of pleurodesis. It is mentioned in many books about what ideal sclerosant should be and they have written it should be of a high molecular weight and chemical polarity, of low regional clearance, rapid systemic clearance, or if it is absorbed should be cleared rapidly, steep dose response curve, minimal or no side effect, and available easy to administer and inexpensive. However, there is no ideal sclerogen as until now. Discussing about some few used pleurodesis agent, I'll be starting with the talc. Talc is a magnesium silicate trilayer sheet which can be administered in two ways as discussed, slurry as well as powders. Efficacy from various literature has shown 81 to 100% in malignant effusion and around 91% in pneumothorax. In short, the procedure it is in slurry talc procedure after the installation of the lidocaine solution in pleural space. 4 to 5 grams sterile graded talc in 50 ml of normal saline can be inserted inside the pleural space and clamped for 1 to 2 hours. So this is the algorithm for the talc pleurodesis provided by the Oxford Handbook of the Pulmonary Medicine. The algorithm shows how we perform the talc pleurodesis. If there is a pleural effusion or proven MP or ICD in situ on free drainage and the lung is expanded properly, and we have seen the proper indication for pleurodesis, we can do the talc slurry pleurodesis as described in the previous section. And if there is a residual pleural shadowing or pleural thickening, pneumothorax, thoracic, other ICD and underwater seal drainage or other mechanical procedures should be adapted rather than the pleurodesis alone. So after the talc pleurodesis, one thing to remember is we should always monitor for the signs of ARDS, excessive pain and anaphylaxis, which is the major side effect of the talc. Talc pneumonitis or ARDS is the most severe adverse effect which should be seen after the pleurodesis. It has an unclear mechanism, but hypothesis is there can be escape of very small talc particles from the pleural space through the parietal pleural pores. And the commercially available talc has two types, mixed and graded, and these complications are usually related to the types of talc used, but they are not related to the dose as well as duration of the chest clamp. Another agent which is most commonly used is povidone iodine. The mode of action is usually unclear, but it has a low pH oxidative and cytotoxic property which induces the inflammation. It is inexpensive and easily available, used in both pneumothorax and MP. Recommended dose of 20 ml of 10% iodopovidone with 80 ml of normal saline administered intrapleurally. Povidone iodine is as efficacious as talc and is easily available at a low cost, and it is also devoid of major adverse effect, as it was reported by Agrawal et al., which is a study done in 2023 from India. And this is the doxycycline, which we also use time to time. It's a derivative of tetracycline group of drugs, which inverts the matrix metalloproteinase and induces a strong fibrosis in the pleural cavity. Dose used is 500 mg to 1000 mg. It is less efficacious than talc, as published by the literature from Reed, C.A. et al. In 1993. And other agents such as autologous blood patch pleurodesis, it was indicated in it was found in used in 1987 by Robinson, and they use it for the spontaneous pneumothorax, and it is also indicated nowadays for spontaneous post-operative pneumothorax with prolonged ear leak for more than 5 to 7 days, which when the patients are unable to undergo surgery. It's a simple, painless and inexpensive way, and it does not induce the systemic inflammation as such. So mechanism is the patch effect of the coagulated blood, which is the site of the leak, and recurrence rate is 0 to 29%. In short, the procedure after the aseptic, we ensure the aseptic precaution, and we inject the 100 to 200 ml of the patient's own blood, and we loop the drainage tube over the drip stand to keep the drainage tube in some height and clamp the tube for 1 hour. If the ear leak is persistent, we should not clamp, and we should avoid the patient rotation, as we should let the blood to coagulate and seal the site. After 4 hours, the original position of drain is ensured and left overnight. If there is no ear leak and lung is expanded, chest drain can be removed on the next day. If the procedure is unsuccessful, it can be repeated till 3 times. On the silver nitrate, in many literatures, it is shown as efficacious as talc for the management of malignant pleural effusion. Here we can see the article from Alexandra et al., where the evidences has suggested that the silver nitrate is an effective agent in inducing pleurodesis in patients with PSP as well as MPE. And this is the last one, as the discussion of all the chemical agents is not possible in the presentation. Bleomycin is the one which we also use commonly. It's a chemical sclerosant. It's a cytotoxic agent. Although 45% of the administered bleomycin is absorbed systematically, there is no evidence of myelosuppression till now. Success rate of 58 to 85% and is found, and it is less efficacious than talc in MPE. It has a fewer side effect, which could be fever, chest pain, and cough. And recommended dose is 60 units with 100 ml of normal saline, with the procedure as described in previous slides. But the one downside is it is expensive, and animal studies have shown that it is ineffective. It induced the ineffective pleurodesis in persistent pleural effusion and is not indicated for non-malignant conditions. So there has been some studies where they compared the chest tube size and pleurodesis efficacy, as well as the use of analgesia in the pleurodesis. The outcome was the NSAIDs were non-inferior to opioids in analgesia and had similar pleurodesis failure rates. And also, as per the chest tube size, 12 French drain had higher failure pleurodesis rate than 24 French drain, 30% versus 24%, although it had significantly better analgesia with the mean VAS score of 22, with smaller drain tube producing lesser pain. So this is the flow chart for malignant pleural effusion adopted from the BTS guideline. After the USA guided thoracentesis, if there is an improvement of dyspnea and the lung is expanded, and indwelling pleural catheter versus pleurodesis according to the patient preference can be done in short. And there is also a rising topic of the rapid pleurodesis in malignant pleural effusion, that is the pleurodesis in a same setting. So many authors have evaluated the response of rapid pleurodesis of malignant pleural effusion, and they have come to a conclusion that it should be considered a viable treatment option for selected patients with symptomatic recurrent MPs. In next article, we will see how they have done the rapid pleurodesis. So this is from the Spegler et al. They have inserted a 14 French catheter was inserted percutaneously into the pleural space after the radiographic confirmation of free fluid, and after the complete evacuation of the sclerosing agent was used. They have used the pleural manometry in this to ensure that the patient does not develop the re-expansion pulmonary edema after the rapid evacuation. Whereas if the pulmonary pressure was more than -20, the tube was clamped and the rapid pleurodesis was postponed. So this is another article from Ozkul et al., where they have also divided the group in two groups, where one group goes the rapid pleurodesis and another group undergoes the pleurodesis as per the available protocol of the hospital where the patient are kept in tube for some days, and after the proper expansion pleurodesis is done. The outcomes, there is complete or partial response, 35 complete response of 87.5%, whereas partial response of 84.6%. The prolonged drain, which ultimately means there were some response of the rapid pleurodesis, and prolonged drainage and hospitalization seems unnecessary if the fluid is completely drained and the lung is re-expanded. The mean total drainage was 2,703 ml in rapid versus 4,229 ml in prolonged pleurodesis, and mean drainage time was 40.7 hours versus 165.2 hours, which had decreased the significant length of stay. This is the last slide. Talking about the complication, there are few complications we should address after the pleurodesis. General complication like infection, which may require antibiotics if severe, empyema, fever, pain or inflammatory response, which can cause systemic symptoms as well. The patient can undergo respiratory distress, especially in case of the talc, and recurrent effusion can be there if pleurodesis fails, requiring repeated intervention. Hypoxia, reduced oxygen level post procedure, and systemic inflammatory response syndrome can also happen, which is rare but may happen with the pleural irritation. Thank you.
Thank you, Dr. Samir. So it was really a very good talk. So the message is very clear, but some things that I would like to raise is, first we must remember what is the normal amount of fluid that is present in a pleural space in adult, and how we are going to visualize that. So normal amount is said, if you take both sides of the lung, it should be less than 25 ml. In an adult patient, it comes around 15 ml in one hemithorax. So if something is more than that, we say that patient has got some degree of pleural effusion. Definitely, not each and every patient requires the pleural drainage, but that is the abnormal. So how can I identify that? We can take the decubitus position of the chest X-ray, we can visualize the lateral position as the PA view, but we have to do both. But X-ray, chest X-ray is not very good for the evaluation of the pleural effusion. So what I think is the best approach would be the ultrasonography of chest, which will detect even the minimal quantity of the fluid which is present in the pleural space, and we can quantify also what is the approximate volume of the fluid which is present in the one hemithorax. So I think from the diagnostic point of view, chest X-ray is good because that is the objective thing. Anybody can visualize, anybody can interpret according to themselves, or radiologists can do it. But ultrasonography is the subject, it is the interpreter dependence. One can say it is no pleural effusion, one can say it is the massive or moderate, etc. So that is radiologist dependent, or the who is doing clinician dependent. Okay. So, but I think the ultrasonography is the best thing to evaluate the pleural effusion. Now, the next one thing is very important to know is he has talked about the pleural manometry. I guess it's a very good thing. If we go theoretically, we must remember what is the normal pressure in the pleural space in a normal patient. So it is negative, everybody has to know. So during rest, the normal pressure is about -5. If we do the deep inspiration, it will come down to -10 centimeter of water. After expiration, it will again come down to the normal value, that is -5. It's again is below the atmospheric pressure. That's why it's the role of the underseal water bag. We don't keep it open in the air space. The second thing, so my question will also be, my suggestion will be, let's start doing the pleural manometry. He has shown a device. That device is not available in our setup. So can we do like CBP manometry? We can attach something in a stand with a scale, putting the patients flat, and at the level of the heart we can have the landmark, the scale system, 0, 1, 2, 3 or minus. So will it be possible to do a pilot study, and let's see whether it represents really truly, and do we have some findings. It means what is the value of the value of the pleural pressure by that way. Did you understand my point? Like we measure the CVP, we don't have a device. CVP just the analyze. How can we measure the pleural pressure? I think this can be done. It is doable. The next thing he said about the very important he missed in his talk is how to prepare the patient for the pleurodesis. It is a painful procedure. It can cause certain mishap that he has talked about the complications, but he has talked about the late complications. Okay, some complication may happen just after the procedure or during the procedure. Therefore, it's very essential to prepare the patient for pleurodesis. We have to counsel them. So it is a painful. It may cause pain. It may cause some rise in temperature, fever. In initial period, it may cause some dyspnea, even may be aggravated. So we have to counsel the patient properly. And very good things. And my practice is that if possible, we have to do in order to avoid the vasovagal attack, syncopal attack. It's better to give the appropriate, if not contraindicated. We have to go to the local anesthesia. Some sort of the intravenous anesthesia has to be given at least 15-20 minutes prior to the procedure. I mean, one of the, you can give the NSAID, you can give some opioids, etc. intravenously, or tramadol, you can give in order to minimize the pain during the procedure. And also very good that you have to instill the lignocaine before he has said inside the pleural space to anesthetize the pleura is very painful. So that's very good he has pointed out. The next thing what he said, there is a controversy whether NSAID has to be given or not due to for the pain control during the procedure or after the procedure. You have to add, because in a malignant pleural effusion patient has got the pain as such. So how would you control the pain in the post-operative period and post-procedure period? So the thing is that it was said that the mechanism of the pathophysiology or pathogenesis of the pleurodesis is that it causes the inflammation. NSAID is the anti-inflammatory drug. So doesn't it counterbalance? You are causing the inflammation and NSAID is causing the anti-inflammation. So in the BTS earlier guidelines, they said the NSAID has not to be done, taken. But right now in this 2023 guideline, they have omitted this. Said there is no there is no side effect. It doesn't hamper with the pleurodesis if we use the NSAID in the after procedure period also. It has been shown even better than morphine. If we give the brufen, there was a trial, I don't remember the trial name. After the procedure, they started with the brufen, the another arm they started with the morphine. They found that brufen has got better pain control and the similar outcome in context of the pleurodesis. So it can be used. So therefore, even the steroids we can use, though it has been said that the steroids, he has mentioned about the steroids acts as anti-inflammatory drug. Now, he has said about some of the chart, he said about the role of pleurodesis in the primary pneumothorax. I think there was something missed there. There are the indications when the patient comes first with the pneumothorax, spontaneous primary pneumothorax, definitely we insert the chest tube. But if the patient comes second time with the primary, in the primary, for the primary but not the secondary pneumothorax, then you have to take the patient for surgery. Or certain at high risk people, like the scuba diving or some altitude, high altitude, low altitude, in those patients we have to do surgery prophylactically. We don't wait for the second pneumothorax to happen. That he has said. Prolonged ear leakage. If somebody has ear leakage, he said 3 to 5 days. I would guess that it's more than 7 days, then we have to take the patient. If the longer ear leakage is there, then we have to take the patient for surgery rather than the pleurodesis. One more thing that we have to add, if the patient has got tension pneumothorax, then those patients, we don't play with the chest tube, we can take the patient for surgery also. Because tension pneumothorax may be fatal for the patient. And he has very well mentioned if the patient has got the hydropneumothorax, then possibly the patient will not be relieved by the chest tubes and the pleurodesis, but we have to do some sort of surgery. So that slide I think was for the indication for the VATS surgery or for the surgical intervention rather than the pleurodesis. Next, it was very well mentioned that when the pleurodesis fails, he has mentioned several types of sclerosis. Very good point he has mentioned when it has to be done. First, if the lung we guess is inflatable, it can expand, then there is a role of the pleurodesis. If the lung doesn't expand, there may not be role of pleurodesis because there is still a space. The drug which you are using will be remaining in the space, it will not cause fibrosis. That is the general thinking. But there is an exception to that. I mean, if we have got the, how will you assess that? We do the chest X-ray, we do the ultrasound to assess the what quantity of the fluid is remaining inside after the pleural drainage. But there will definitely a minimal amount of fluid present. There will definitely some amount of fluid which may be floated. Therefore, we have to classify if we insert the chest drain, and after that we radiologically see the lungs expanded, that becomes the indication for the pleurodesis, right? In the context of pneumothorax or in the context of recurrent pleural effusion. In the prime, it resolves the may not require any sort of the chemical pleurodesis, but in the context of recurrence, malignancy or malignant pleural effusion, recurrent pneumothorax, it has got the role of the pleurodesis. So that can be evaluated by cystectomy, that can be evaluated by the ultrasound. But nobody knows in the ultrasound you may see a space there between the parietal and visceral pleura with some potential space, some loculation. At that point, you can attempt for the pleurodesis. If there is the minimal, nobody knows what does it mean, what is minimal, but in the chest X-ray you can see the complete expansion. So the best success rate is achieved when there is the complete expansion of the lung, which we can visualize by the chest X-ray, defined on the ground of the chest X-ray. And the second very important point he has said, quite often we have got the failure after the pleurodesis. Why? Because if the chest drainage, chest output is more than 150 ml, that he has mentioned very well in this slide, then the failure rate is higher. Though we can attempt it 200 ml, 300, 500 ml also, but it will be diluted, the drug we use, it will be diluted by heavy production or less absorption of the pleural fluid, and therefore it may not act as properly as there is the minimal quantity of the fluid. So it is good idea to wait for some days so that the pleural drainage will be decreased to less than 150 ml. I would say up to 4 ml per kg per day. For some patients it will be 200 ml, some patients will be 150 ml, some patient with less height and weight it may be even lesser in amount. So that is very good thing. So this is why the failure happens. He has mentioned in one of the slides that if somebody needs the pleural drainage for more than 10 days, that becomes an indication for surgery, right? He has mentioned in one of the points. So why do you think the chest tube longer than 10 days will be not indicated, will be taken for the surgery? What's the point behind that?
There may be space.
It means it means that in a non-malignant case, really, so it means that the patient will have, we are creating more empyema, pleural space infection rather than any sort of advantage for the patient. If the ear is leaking or the chest drain is there and the pleural fluid is leaking for a longer time in non-malignant effusion, then definitely we have to reconsider, we have to redefine maybe the patient requires the surgery. Definitely there comes in a malignant pleural effusion, even the lung is not, you inserted the chest drain, quite often what we see after insertion, the lung is not expanded, rather it will have the hydropneumothorax, because the lung is not going to expand in the context of trapped lung. So in those cases, if it is the malignant effusion, the best thing will be the chest drain, indwelling pleural catheter. Why? Okay, why do we put, even the lung doesn't expand, but we prefer the indwelling pleural catheter, even the lung is not expanding in a context of symptomatic malignant pleural effusion. Any idea? The reason is that indwelling pleural catheter by itself causes the autofibrosis. It promotes the fibrosis, and therefore in a greater span of time, because indwelling pleural catheter is meant to remain there for some months. It is for palliation for some months, so during this time there will be the fibrosis, and hopefully after 2 months or 3 months time it will be possible to remove the pleural catheter. So that's the indication of IPC in the context of malignancy, even the lung is entrapped. So that we have to do. The only thing is the expense. He has very well mentioned what type of chest drainage tube do we require. So BTS guidelines says that it's 12 French of chest drainage tube. Anything more will not be beneficial for the patient. This was proven by the Time 1 trial, and according to that, 12 French has been the standard practice. But definitely, he has at the same time mentioned what are the disadvantages of the 12 French. So we should be very subjective. If the patient has got thick turbid fluid, we shouldn't use the 12 French tube because it will be blocked. Second point, if we use the 12 French catheter, then what happens if you are using the slurry? It will be blocked by the slurry itself. So definitely in that context, maybe other sclerogens can be used better than the slurry. He said very repeatedly, Pleurodesis and the slurry, they have got the equivalent results, right? So what do you prefer? So if we are proceeding for the surgery, for example, diagnostic VATS, or some reasons we are taking the patient for the biopsy with the surgery, I mean the VAT surgery or whatever, pleuroscopy. So at that point, it is better to instill the powder that is got better efficacy. That we use just like manometer, something pump by the squeeze garden powder throughout the pleurodesis, so that will cause the talc pleurodesis. Definitely, he said there are certain the talc is the best drug. He has been emphasizing throughout his lecture that the best sclerosant is the most powerful sclerosant is the talc. The only thing you have to mention it very properly, this is called the medical graded talc, not the simple talc, because it must be asbestos free. It should be medical grade. It's different from the talc which we use generally normally. So the amount of talc that we use should be 4 to 5 grams. That's right. In our part, it costs about 8,000 rupees. So not each and every patient may afford for that. That's why we are looking for some another sclerosants like betadine, etc. This is also very good agent. But one of the very disadvantages of talc is that suppose the lung is not expandable. In those cases, we should not use talc. You have inserted the chest tube, you see there is a coarse amount of fluid or hydropneumothorax is there. The talc will cause more empyema, more fibrosis. For example, those patients are taken up for the surgery, decortication. That will be very challenging for the patient because it causes localization of the fluid and dense adhesions like the proline mesh infection. Mesh infection, you have to repair again and you have to remove the fluid that will cause very dense adhesions. So similar things happen in the pleural space. So that is one disadvantage that I would say. If the patient requires surgery after talc pleurodesis, then it is very difficult for the surgeon, definitely for the patient also. So the take-home message should be, I think it was very good talk, it's very beneficial. The take-home message should be, pleurodesis is definitely very beneficial. First indication should be the recurrent pleural effusion, recurrent pneumothorax, even the primary pneumothorax we can use that. And the choice of the drug, choice of the sclerogen should be talc. Talc चाहिँ सबभन्दा राम्रो मानिने हो भनेर चाहिँ हाम्रो यही हो. The chest drainage tube, if it's not very turbid fluid, then we prefer the smaller bore catheter like 12 Francis as equivalent to the 24, etc. So that is very good. So far as the chest bottle is concerned, it depends upon the operator, upon the clinician. What is your mind behind? You can use the simple double, you have to attach with the suction. Then definitely you have the triple bottle system or synaptic system like we have been using. So those things have to be considered. Any questions? Any more comments? You will like a basic thing, but very useful, very genuine thing is you brought out. Yeah?
So it's more like the latest product position change or something.
So very good point. And initially it was initially